Welcome to Discover Health, a White Mountain perspective. I'm your host, Dr. Tom Barela. Today's program should be interesting for almost everyone because we're going to talk about how our community discovers, investigates its own community health from a health standpoint, not from an economic standpoint. And to do this, we've asked Allison Hephner from the County Health Department to be our guide through the County Health Assessment. She is the outreach coordinator for the County Health Department. And I'll say, welcome, Allison. You have a lot of titles and you do a lot in the county, but this is an important piece of information, is it not, for our county?
It is, and it's my favorite. This has been my favorite project ever.
And it's very extensive because the materials you sent me before our talk today were really extensive and in depth. It must be hard to really come up with an objective assessment of a community's health status. I guess a person goes to the doctor to get an idea how healthy they are and what might be a problem. Is this not what you did for our community?
We did. Navajo County, what previously when we had done this before, every different health agency had their own objective viewpoint of the community health. Each different agency did their own community health assessment. So there was a lot of different community assessments at one time.
Kind of siloed in particular interests.
Yeah, still valuable,
Right.
Definite to the community. So this time we did it a little bit different in Navajo County Public Health. We went out and we developed partners with all of those other health organizations that were doing the same thing. And what was exciting about that and what's really allowed us to be more objective is because we partnered with all these different health care agencies, and even MPC was involved in it, and Arizona at Work was involved, Summit, North Country, Change Point, and we came together and we were able to help each other to see where we needed to move forward, to try to see what data we needed to collect, see what data we had. We were able to look at other CHAs and say, okay, this is what you did at that year. This was great for the questions that you asked the community. We were able to come together as an advisory board and really see where our strengths were and where our weaknesses were, and address all those before we went out into the community and started to assess.
Now, CHA is the community health assessment?
The CHA is the community health assessment,
okay.
Yes, it is.
Just so our audience understands the abbreviations.
Yes, and I'll throw a couple out there, so please stay on top of me with that.
I will.
Thank you.
Okay, so all these organizations, and you came up with, as a result of this collaboration, you came up with
We came up with the plan to move forward with the community health status assessment and what we were going to move forward with. So in doing that, we got to seek a contractor. Her name is Mare Schumacher. She's with Mare Insights. And she's an epidemiologist, and which was huge to have. And she was able to help guide our process. I guided the project, she guided the process. And our teams, our advisory team, our MAP meeting, Mobilization for Action, Planning, and Partnership meeting, we'll talk a little bit more about that, guided the direction of where the community was taking it. So the advisory group did it from a health care standpoint, while the MAP committee did it from a community standpoint. So that's what was exciting, is when we started moving forward in the process, we were able to roll this out to the MAP committee meeting, which was 52 agencies, organizations, which included nonprofits, which included anything from economic different organizations to community members. And they came together on January 1st, 2018 to discuss what health in Navajo County looked like and what resources we had and what they wanted to see us focus on as getting in, accessing data and who we could reach out to get more data from. I mean, it was an incredible meeting. And so we left that meeting, and Mare, myself, and our epidemiologist, Edwin, would meet weekly and discuss, okay, they wanted this, or they needed this, and we need to, create this. So we were making the advisory group happy, we were making the MAP meeting happy, we were working that whole system.
But what were you doing? Were you looking for data sources?
We were setting up the process. So within that was, the first part of that process was the community health status assessment. And that was the survey that we rolled out to the community. We wanted to make sure it was representing the healthcare part of it and the community part of it, that we were addressing.
So you had a survey that you sent out to
everybody and anybody. We promoted that. All of our partners promoted that. All of our community members that we could promoted it. We had promoted it on Maverick Magazine and White Mountain Independent, Birdman Media, you name it, we promoted it everywhere. We even promoted it on Sholo TV. And we tried to convince the community to take it. And we were able to convince 1,108 community members to complete the survey. And when I say complete the survey, we had about 498 who did not finish the demographic part of it, and we could not use their information. So I would encourage people, if they take the survey, to please.
Well, I think you need, because I think you need to indicate that at the beginning, that if they don't complete the demographics, that it'll be negated. Because I did complete that, and I just.
That's a great idea, and we'll do that in the next one.
If you don't pull the demographics, we can't use it. Well, so essentially, over 1,500 people in our community
came together
and
took that survey.
That's pretty good. That's probably 2 to 3% of the community.
It was the best, per our contractor, it was the best she's ever seen in participation into a survey.
Okay, so we have a representative sample.
Yes.
Of a lot across the community.
Yes.
And
then so from there, we wanted to take that report, because it ended up coming out as a report, and actually turn that into 2 focus groups. And we had a focus group in Winslow and a focus group in Sholo. And those focus groups had to be people who had nothing to do with healthcare, nothing to do with any agency that provides resources or services. We wanted the woman at a Circle K behind the counter. We wanted somebody who worked for maybe a utility company over here. We wanted those people in the survey, and we got them. And it was incredible. They gave us the statements that went into our community health status assessment. They gave us, they pretty much took what was happening in what we saw in the community health assessment and verified it and added to it. So that was good.
So essentially you had some preliminary data, and you present that you got from all these 1,100 people, and presented it to focus groups and said to them, what do you think of this?
Yeah, what do you think? How does this make you feel?
Does this feel appropriate from your feelings?
Yes.
And that
so
validated
honest.
it.
Yeah, they were so honest and so exciting. I mean, they would say everything that they say. One person said, all of people in the community want counselors. We don't have enough counselors. We need more counselors. We want that. It was they were direct. They knew exactly what they wanted. They knew exactly what they saw in the community from the ground. It was amazing. It was really cool to see. So then from there, then we went into the data and what data we had to collect, because from the survey and from the focus groups, we knew what was going on in the community, what we wanted to assess, from the MAP group as well and the advisory group. So we took all of that information, and Mayor went out and was able to get a lot of data using like the Arizona Department of Health Services, DES, DDD, all these other agencies, as well as our advisory group. All of our advisory group provided their data. Summit provided data, ChangePoint provided data. So we got data. This is the first time we've had such a comprehensive community health status assessment ever. And it was because of the partnerships that we had created.
So essentially, we better pay attention to the results of the survey.
Yes, it really shows what our community is saying about their healthcare.
So let's go through some of the things that we found out. Okay, now, tell me some of the good things. What do people think is really great about the mountains?
You always want to start with the good. So
I want to start with the good stuff, yeah.
So our air quality. We have really great air quality.
Right.
It's something that we have. We have incredible community. We have, I mean, how many times you go to Walmart and instead of for, 5-minute thing, you're there for 2 hours saying hi to everybody.
Hi to everybody.
Yes, we have an incredible community. People come together and help. We have that small town feel. We have hiking and trails. I mean, we have people coming up during the summer just to visit our trails and walk through our hiking systems. We're a resource of relaxation in a way to the community.
I hope so.
Yes. So there's a lot, and we actually in our survey we found out that the majority, I think it was 78% of our community knows what good behaviors are, healthy behaviors are. They know it, but are they doing it? The data
That's
says
always a different. And you know, it's interesting that they say that because we may put such a great effort into education of people on healthy habits. It's surprising with that one of the top priorities was an unhealthy priority. So let's look at a little bit, and you can send me some information about and statistics, and I know you don't have this at your fingertips, but you essentially say that for the old population, seniors, half of our county seniors have a disability.
Yes.
Half
Yes.
my age.
Yes.
And they also indicate here that 56% of county households have a person in their household with a disability.
Yeah.
Impressive.
In fact, our survey came back that 21% of our household has a child or adult living in the household with special needs.
25, yes.
21%, yes.
Yes. And
Which was huge.
1,100 people in our community, that's what, 15% or so, live in poverty?
11,000.
11,000, thank
yes,
you.
11,000, which is 30%
Okay.
poverty, which is huge.
So we're going to go through for the rest of the program some of the 5 things that you discovered as the top priorities in our community. And I just want to say, from a physician standpoint, we think of medicine as 3 elements of every problem. We think of prevention of the problem, we think of detection of a problem, and then we think in terms of treatment. And so let's go through some of the things that we found were the top 5 priorities in our community. And I'm just going to list them rotely here.
Okay.
And then we'll go through them only in case we run out of time, which we usually do. And these are in no particular order. Are they in particular order?
They are in a particular
Okay, so
order.
the number 1 thing is substance abuse.
Yes.
Number 2, poverty.
Yes.
Number 3, mental health. Number 4, chronic diseases. And number 5, sexually transmitted diseases.
Yes.
So let's talk a little bit about substance abuse. What do we do in our community? I mean, it's a significant problem.
It is.
How do people usually come to know that we have a drug abuse problem in the community?
Well, it's alcohol actually abuse is our biggest.
Okay.
It's 4 times higher in Navajo County than the state of Arizona. And with the alcohol abuse, it comes in the death records. It's all the people who have died from alcohol abuse in a year. Our opioid abuse is also higher than the state of Arizona. I think the state of Arizona is like 20 and we're in 22. Or something, you know.
A little bit higher.
A little bit higher.
Yeah.
But opioid addiction is an issue all over. Federally, they've said
And we've had some very big programs in our community to try to approach the opioid addiction.
Yes, and I think now they're getting more support
Okay.
now we have the proof, we have the data to show that this is a problem in our
significant
community,
problem.
and we're addressing
I mean,
it.
we can't ignore it in our community? Okay.
No, we can't. And what we're doing is we're coming in with partnerships, and we have a subcommittee that's coming together to address this. And right now we're working on accessing data. We want to be able to show that what we're doing is working. And data shows us that, yes, okay, if we implement this plan and we're doing this much, the data actually can help direct whether it's making an improvement or it's not doing anything. So then we can sit back and we could reassess what we're doing and make sure we implement something.
So the county has a prevention arm. There's a drug
Yes.
abuse coalition here and
Yes.
a nexus here. And detection sometimes is difficult relative to the legal system, accidents versus probably very low diagnosis by physicians and referral. And then treatment is still a significant issue.
Well, we suffer, we don't have the resources.
Yeah, because we don't have the resources for the treatment of substance abuse.
Which we're working on in partnership to bring more resources to this. If you're not in the community health status assessment, then you don't have the representation to where we can focus on bringing in the resources. We have proof that we have a problem and we need help. And so now we can go out and get that.
What do you mean by not being, if you're not in the community health
So,
assessment?
for instance, with children with special health care needs, they were not viewed they were not a data in the community health status assessment. So people come to the community health status assessment, show the data, is able to get grants, able to get the resources, able to show the need. Community health needs assessment. It shows the need.
Okay.
So if you can't show the need, then you don't get the support for that need.
Oh, I see.
Do you understand?
Yeah.
There? Okay. Sorry. A little bit more direct. Yeah.
Slow.
I'm a little too fast.
You do talk fast.
I do. It's exciting.
Okay, so number 2 is an even more significant issue in terms of poverty.
Yeah, and it's going to sound bad to say this, but I was really excited to hear this because we see poverty all around us, and because it's been identified, we can actually start to address it. That's where my excitement is. And we're addressing it in partnerships throughout the community to build a resource web portal that all the resources that people can access can be in one spot. What usually happens in our community right now is somebody has to really work hard to access resources or to even find where to access those resources. So we want to make it easier. Does that make sense to you?
Well, just in terms of thinking about the audience, I mean, if poverty is an issue, then one of the resources must be a community approach to bringing jobs into the community, community action type program.
I think one of the things that we have is we have a very we have people that need, like our workforce, Arizona at Work. Arizona at Work, what they do is they help provide the training an individual needs to get that job or to access jobs.
Okay.
And I think that because of our education, if you look back in our child, we have a very low college education rate. When we have
much lower than the state.
But much lower
than the state.
So we need those jobs. We need to be able to prepare people with the knowledge to be
Right.
able to get these jobs. So that's where we're coming at. We want to give the community the resources so that they can take individual responsibilities to get those better paying jobs or even get jobs.
So part of it is to create an educational system that allows people to attain a higher level of education, which
Or
of course,
job training skills.
job training skills. And yes,
them to
everybody,
those.
whatever the skill is, everybody doesn't have to go to college to develop a skill.
Well, and along with that, then you have somebody who is in poverty who has doesn't have access to health care, doesn't have access, maybe she's pregnant, doesn't have access to WIC. We need to give them these services so that you can limit the amount of issues they have so they can start focusing on their career or focusing on getting out of poverty. And so that's where this resource web-based center comes together. Eventually, we hope to have a brick and mortar building where somebody can come in and access all those resources and have a hand out, like one person takes the person and says, oh, this is so-and-so. They need this resource now. And then you can have people case manage those people.
It's always nice to develop a single focal point for that.
And then case management of these people to make sure that they are meeting their appointments, because it takes 28 days to create a habit. So we want to create a habit.
Good habits.
Good habit, yes.
All right. So the next thing on the list is a real difficult one, I suspect, is mental health.
Mental and behavioral health has always been on the list. Usually it was a lot higher. So one of the things that we're doing is we're trying to address work wellness and mental health in work. There's a lot of stressors. And so we're working on bringing in the ability to maybe individual responsibility, maybe help people to understand that maybe you need to step back and take a breath. Maybe corporations up here can provide wellness programs that might help somebody a little bit better. We're working on that and seeing where we can go to provide a good example of this. And I know that chronic disease is our next one. But sometimes when a person has chronic disease, it can make them very depressed. Their quality of life is down. Public health has a free chronic disease class. If that was provided to maybe a corporation saying we can come in and we can provide this class, then maybe they wouldn't be so depressed. Maybe they wouldn't hurt as much. Their quality of life could be a little bit better. We're trying to find where the right niche is in that, the mental health. And so we're working with emergency management to provide how to take care of yourself at work, be mindful. It's just like caregivers, the stress that caregivers have. They need to take care of themselves. So it's kind of that approach. And then to also get into schools, more talk about suicides in schools. And because our teen suicide rate is very high. I think it's 2 times higher in Navajo County than it is in the state of Arizona. And so we want to address it from a school approach as well. So we're working on developing the partners for that right now.
Yeah, and on this program, we've interviewed Dr. Garcia about mindfulness types of issues and Kara Quaid from Change Point on depression, which of course are part of the mental health. But, the whole country is seeking mental health workers. It's just an incredible, and we've always stressed the difficulties up here for children under 18 with any mental health problem. In the past, it was all done through telehealth, through community counseling, and now through ChangePoint. It's very, very difficult to find adequate resources everywhere. Even in Phoenix, there's a shortage of mental health workers, especially psychiatrists, which we have numerous psychologists up here, but of course they do not treat any mental health illnesses with medicine.
No,
which is the difference between psychiatry and psychology, is the psychiatrists can use medications, where the psychologists basically use therapy type modalities and stuff like that. So from a treatment standpoint, we're looking at developing additional resources up here.
Absolutely.
Okay. So let's go to number 4 then, chronic diseases.
Yes. So
we have 2 baddies up here.
Yeah, heart disease and was it cardiovascular disease and cancer. Number
and
1
also
and number 2.
diabetes.
Diabetes is a big issue. Yes, it is. Yes, it is included in that.
Well, it's interesting that those 3 diseases, and I know the hospital is working hard to develop the resources for cardiovascular disease and cancer. I mean, our hospital has a new cancer center. They have cardiovascular, increased their cardiologist inputs up here. Diabetes is always a problem because we don't have an endocrinologist up here, but
no, and a lot of people don't realize that they have diabetes. Oh, I take a pill for it. Well, if you take a pill for it, you have diabetes.
I have heard that. I have heard that previously. And of course, one of the difficulties is that the Native American population in our county has a much higher incidence of type 2 diabetes than the Caucasian population around us. And White River, of course, has been a national study site for years about the incidence of diabetes and stuff. And so prevention needs to be a big piece.
Absolutely. And we have that. We have a chronic disease self-management class that teaches people how to manage their diabetes as well. And the hospital has that.
Right.
We just can't get people there. We can't provide the class because people don't come to it. So we're trying to find unique ways through the workforce to maybe bring the class to them that way.
And that's a perfect thought process. And the hospital, I know, is trying to bring more specialists up here to make the travel to Phoenix basically less necessary. I won't say unnecessary, but less necessary as an approach.
Yeah, it's a financial impact to an individual when they have to travel outside the mountain.
Yeah, and prevention is always a big thing with diabetes, heart disease. Not much for a lot of things. Cancer is genetic, and so that makes it a little bit difficult. Detection, we have the facilities up here are expanding, and then of course treatment becomes an important issue. But it's impressive that it's such a high incidence, and we also have the approach to solving some of those issues. And number 5.
Yes, and
it amazes me. We've done programs on this topic previously, and I'm not sure basically how to get that. And number 5 is?
It's sexually transmitted diseases. And the problem with number 5 is this didn't come up on any of the assessments in any of the focus groups, but it came up all in the data. The data was there. Syphilis increased by 800% this year. 800% syphilis cases in Navajo County. This is a county-wide problem. This is not a reservation-specific problem. This is all of us. It includes the reservation. It includes Pine Top, Show Low, Lakeside, Holbrook, Heber, Winslow, all the areas, as Snowflake, Taylor. We all share in this. And yet, nobody wants to talk about it.
Nobody wants to talk about sexually transmitted diseases. And we've actually talked to the head nurse at the health department, Janelle Lynn, about this a couple years ago. And it was impressive to me that statistic was present 2 years ago.
Oh.
And it's still there.
It's been decades. We've been number 1 and number 2 for chlamydia and gonorrhea in the state of Arizona. And Apache County is either number 2 or 1.
Or number 1, yes.
Yeah. So we share this with Apache County, and we either have to fix it or be proud of it. I don't know what to do.
Well, we aren't going to be proud of it.
No, it's not.
We aren't going to be proud of it. And we actually had an issue about it because we were named in the top 50 counties in the country.
Oh yeah, we're getting a name out there for this.
Our name is getting out there for the wrong thing.
Yes.
And I wonder why it's been so difficult of an issue to deal with. And
it's not a comfortable topic to
Right.
talk about. People don't want to talk about this, and then other people say, well, it's not us. And that's the problem. One thing that I am very proud of, and I've seen, is White Mountain Apache Tribe is addressing this and has been for a while. And they bring speakers in and to talk about it, and they're very proactive in addressing what's happening on their reservation. Outside of that, we're not as proactive.
the county health department has a free clinic.
We have a free clinic. We have
That's
an incredible-
anonymous?
It's so anonymous, and I think it's 12 years old and up. 14 to 26 is the realm of where these sexually transmitted diseases are the highest. But we provide, our nurses and our clinic provide an incredible case management when it comes to that. You don't just come in and get checked and here's your pills because you have something, and your sexual partners or sexual partners, bring them in and we'll treat them. No, they sit down and they counsel you on your sexual behaviors and how to have a healthy relationship or a healthy sexual relationship. It's information. It's accessible.
Okay, so we're almost out of time.
Oh,
It
darn it.
always goes quickly. Where do you go now?
We go now into our subcommittees, and we go now into identifying strategies, implementing those strategies to address these issues in our community, to fix them, to make it better.
Not only these 5 issues, but other issues that came up too. But these are your highest priorities?
Those are our priorities. Actually, we're addressing those priorities countywide with all of our partners. So those are the 5 that we're focused on. Now, sexually transmitted disease, public health is focused solely on helping that one out. People won't come to the meetings for that one, but we will fix
the
it.
52 organizations we have in this county, these people are involved in implementing and making this survey valuable, because without community input and community effort, this just becomes an additional statistic that comes up again in the next community survey. I thank you for watching, and I thank you, Allison, for being a guest today and talking about this wonderful survey. And I would ask you all to keep healthy, and if you're asked to participate in the survey in the future, do so, because it really helps us progress. And thank you for watching Discover Health.